MD Community Medicine.
ঠিক আছে।
Uma, you have the
Yes, sir.
presentation ready, na?
Yes, sir.
Like to share your screen and then.
Yes, sir.
Okay. Good morning. Today we have two important shortcut discussion. Dr. Uma Murmu is a second year junior resident at IPGM SKM Hospital will present. And with us today is Professor Shubham Maiki, who is Professor and Head of Eye Care Institute of Medical Sciences at Holdia. Dr. Maiki will moderate. Uma, you present. You can present the whole case because it's short case. You present the complete case, including history and examination, and then we'll proceed with the discussion. So, it's
Yes.
a case of hypospadias.
So is the slides are visible, sir?
This slide is visible.
Okay. Good morning, everybody. I am going to present two short cases today. The first is on hypospadias. My patient, Mr. X, who is a 4-year-old child, resident of Midnapur, and informant being mother. His chief complaint is that he's passing urine from the undersurface of penis since birth. Coming to history of present illness, the child is having difficulty of passing urine from the undersurface of penis since birth, and the child is passing urine preferably in the sitting position. The child is having difficulty in directing the stream of urine, and no history of burning micturition or fever or pain. Treatment history, there is a history of correction of ventral curvature of penis, that Cordy correction 8 months back. His birth history, antenatal history, it's a non-consanguineous marriage, and maternal age is 24 years. No history of any OCP uses. Birth order, it's a first birth order. It's a term baby delivered by normal vaginal delivery, and cried immediately after birth with birth weight of 2.8 kg, and the child is exclusively breastfed. And in postnatal history, nothing significant, and all immunization received as per the schedule. His personal history, he's having mixed Bengali diet, and his sleep, appetite, bowel habits are normal, but in bladder habit, he is passing urine in the sitting position, and socioeconomic status is poor. The family history, both the parents are healthy, and he's a single child. No other member of the family suffers from this condition. Summary: a 4-year-old male child presented with urethral orifice opening on the undersurface of the penis since birth, and he has difficulty in directing the stream of the urine, and the child has a history of surgery for Cordy correction 8 months back. I've examined the patient in supine position after taking proper consent from the child and his mother, and exposing from umbilicus to mid-thigh. Hello. In general examination, the child is active, alert, and playful. The child is well built and nourished. There was no pallor, icterus, cyanosis, clubbing, or edema. His height is 105 centimeters, weight 20 kg, and mid-upper arm circumference was 16 centimeters. No other congenital difficulties, deformities detected. His vitals, 96 pulse was 96 beats per minute. BP was 100/66. Respiratory rate was 18, and temperature, he was afebrile at that time, and 100% SpO2 saturation was 100% at 2 minutes. On examination of the genitalia, in inspection, the urethral meatus opening was exactly at the middle, and on the ventral aspect of the shaft, and not at the tip of the penis. The size of the penis appears small. The penis has no curvature in the shaft. That means no residual cordy was there. When asked to void urine, he did it in a sitting position, and there was a narrow stream of urine, and the direction could not be controlled. and the scrotum, no obvious abnormality noted. On palpation, the stretched penile length is approximately 4 centimeters. There was no chordae, no residual chordae. The glans is well developed. The meatal opening present at the middle of the penile shaft on the ventral aspect. The urethral opening at the end of the penis was absent, and bilateral testes were normally descended. Bilateral hernial orifices were normal. In the systemic examination, nothing seen, apparently with a normal limit. Coming to the summary of the case, a 4-year-old male child presented with urethral orifice opening on the undersurface of the penis. Since birth, he has difficulty in directing the stream of the urine, and the child has a history of chordae correction 8 months back. On examination, the penis appears small. The urethral orifice.
Mr. Subhabrata.
Hello.
Others, please mute.
The urethral orifice is situated at the middle of the ventral aspect of penis, and he has no chordae. There is no other congenital anomaly. So my provisional diagnosis is the case of mid-shaft penile type hypospadias in a 4-year-old boy.
Okay.
Hello.
Hello.
Yes.
Hello, Uma. Uma, thank you
Yes,
for
yes.
your case. You have nicely presented the case. You have mentioned almost all the important points. And your final diagnosis or provisional diagnosis, a case of mid-penile hypospadias in a 4-year-old boy. Okay.
Yes.
As the chordae correction you have mentioned in your provisional diagnosis, you should also include that.
Okay.
Chordae correction has already been done 8 months back. Okay.
Okay.
And
yes.
you should also mention in the final diagnosis or provisional diagnosis, there is no other congenital anomalies detected. Okay. Because that has some bearing. If there are other anomalies, for example, if there is bilateral undescended testes, what you will think for? If it is a hypospadias with bilateral undescended impalpable testes, then what you will think? What you keep in your mind? That case may not be a male child. You should, that may be
ambiguous
problem, intersex problem. Okay. It may be a case of congenital adrenal hyperplasia where the clitoris is long and there is hypospadias. Okay. And if it is a unilateral undescended testis, what will you think for? Suppose it is a case of unilateral undescended testis with hypospadias.
With hypospadias unilateral.
Yes. Unilateral undescended testis with hypospadias. There is a condition which is known as mixed gonadal dysgenesis. Okay. And that testicular testis may be present, but testicular hypofunction is present. And the genetic background, it may be 45XO. Okay. So that means that no other congenital or other abnormalities detected in this patient that should come in your provisional diagnosis.
Yes.
So you have mentioned the patient is having difficulty in micturition. What difficulty the patient is having?
The patient is cannot control the direction of this stream of the urine.
Okay. So
kind of spraying.
So what are the difficulties the patient may have other than the direction? Other than the direction only.
Sir, if there is a chordae, so in childhood there will be
chordae.
So if
what
there is chordae,
what about the orifice? Can there be any abnormality in the orifice? Whatever it is,
there can be stenosis in the orifice.
Yes, right. So not only the direction, but also the stream, the dimension, the breadth of the stream. It may be very narrow. Patient may take long time in passing the urine. Okay, the stream may be narrow because of the pinhole meatus. In this patient, there is a mid-penile hypospadias. So what is your knowledge that whether this pinhole metas will be more common in proximal penile hypospadias or distal penile hypospadias.
Pinhole.
And
Sir, in distal.
Yes, this pinhole metas
Distal
or
one.
narrow metas is more common if it is distally present.
More distally present.
Yes, in anterior hypospadias. Okay.
Yes.
So this is a mid-penile hypospadias. What are the other types of hypospadias? How to classify hypospadias?
The hypospadias is classified as according to the position. So
Yes.
if we come from distally to proximal, there is a glandular, which is just proximal to the originally where the meatus should present, and then coronal, subcoronal, and in the middle portion there is a distal and mid shaft, and then proximal, and in the a posterior one there is a scrotal, then perineal.
Perineal. So if it's a scrotal or perineal type of hypospadias, what abnormality you may get in the scrotum?
Sir, it may be underdeveloped scrotum,
Not only
and undescended testis also.
And bifid.
And also bifid.
Bifid state.
The scrotum may be bifid.
Bifid.
Okay. So will you expect any other internal abnormality in this patient? Will you examine the abdomen?
Sir,
is there
any other
testes are descended?
The
testes are descended. So
will you think for kidneys, upper urinary tract?
So if there is continuous like pinhole meatus or any continuous obstruction like this, there can be backward pressure, so hydronephrosis can be present.
Though the upper urinary tract abnormality is less common in the distal hypospadias, yet routinely you have to examine the abdomen. In an exam, you have to examine the abdomen to exclude the presence of hydronephrosis. Another abnormality which may be associated is the agenesis of the kidney, but palpation of the abdomen should be done in case of hypospadias. Okay. Any other abnormality you may expect in the lower urinary tract? Can you mention that?
Patient will have obstructive symptoms.
Other than the stenosis or meatal stenosis or the pinhole meatus, in the urethra itself, in the proximal urethra in a male, some abnormality may be there, where the catheterization of the patient may be very difficult. You may not be able to introduce the catheter into the urinary bladder. What abnormality can cause this type of problem, where you are failing to introduce the catheter into the bladder? Suppose you are doing the operation, keeping the catheter in situ, but you are failing to introduce into the bladder. If you know the answer, you tell, otherwise I will tell.
No, sir.
Okay. So this is the enlarged prostatic utricle. What does the prostatic utricle represent in a male patient?
Prostatic utricle.
That is the proximal vagina in the female. That corresponds to vagina in the female. Okay. So why the prostatic utricle may remain very wide, or it remain as a rudimentary female genital tract in a patient with hypospadias, in a patient with severe hypospadias or proximal hypospadias? What are the hormones with regulates? What are the hormones which regulates the development of external genitalia in a
the testosterone.
Any other hormone which is also responsible for the inhibition of the female or paramesonephric duct? Mullerian inhibiting substance. Two hormones are important. One is testosterone, one is MIH. Okay, that inhibits the development of the female genital tract. So if that hormone is also deficient, that can lead to the presence of associated presence of the female genital tract along with hypospadias, particularly the proximal hypospadias. Okay, so this patient you say that body correction has already been done. So what is your finding in the prepuce in this patient?
So it was looking like a circumcised penis.
Circumcised
No, not
should have been
circumcised.
done.
But it was looking like, but the patient
like.
didn't
Have you
give history.
examined the dorsal and ventral aspect of the prepuce?
Yes, sir.
Yes. Okay, so you tell that there is some scar mark on the dorsal aspect in the distal part of the penis, and that scar mark is due to the prepucioplasty. So prepuce was brought from the dorsal to the ventral aspect for the correction of the body. Is it, Uma? Do you believe? Okay, so it may look like circumcised, but
Yes, sir. Yes, sir.
okay, but circumcision is never done in case of
yes, sir.
okay. So all Muslim patients particularly, they should not go for ritual circumcision if hypospadias is detected, because that prepuce is very precious for the reconstruction of the urethra.
Urethra, yes.
Okay. So in this particular patient, so what investigation you would like to do? How to proceed?
And another thing, Dr. Maiti, Uma, there is a definition for hypospadias. There are 3 criteria to define hypospadias. What are the 3 criteria?
So first, there should be an abnormal ventral opening of the meatus, which can be located anywhere from the ventral aspect in the glans
One is
penis
abnormal
to the
location of
perineum.
the urethral orifice, number 1. Number 2
is the abnormal curvature, ventral curvature of the penis. And there is the foreskin, hooded foreskin, which is present dorsally, and the foreskin is deficient in the ventral aspect.
All 3 criteria may not be present, but these are the 3 important criteria used to define hypospadias. A patient may have 3 also. The ventral opening is mandatory. Apart from this, other 2 criteria may be present. Yes.
Okay. Uma, can you tell me what are the other important anomalies other than hypospadias in this particular region, which may be the presentation? Have you heard body without hypospadias? What is that? Body without hypospadias?
Body. No, sir.
No, actually, that is a patient with significant body. That is significant body. The penis is bent, but the opening is at the tip in the glands in this normal position. Okay, and that is due to the gross fibrosis or absence of corpus spongiosum. Okay, there are different grades. We're not discussing that, but you should remember that entity, and the management is also little difficult in those cases in the presence of severe body without hypospadias. Body without hypospadias.
Body without.
What is congenital anterior urethral fistula? Congenital urethral fistula. That should come in the differential diagnosis, because here there is an opening on the ventral aspect, but at the same time the patient will have the normal opening at the tip of the glans. That entity you should remember. So if you find a opening on the ventral surface of the penis, you should also look for any extra opening at the glans, tip of the glans. So that is a congenital urethral fistula. Okay, that may be due to some ischemic necrosis on the ventral aspect of the penile skin, though the patient has having normal urethra in the fetus. Okay. So, then Makulad, any other question, clinical question?
We can discuss a little about urethral development, because that will explain the...
Tell in short the embryogenesis of this defect.
How does a normal urethra develops?
So the urethral plate develops from the urogenital sinus, and there is a urethral groove, and the urethral folds on the ventral aspect, and these urethral folds fuse ventrally in the midline to form the urethra, and the distal portion of the urethra is an ingrown part, which is coming from the surface epithelium, and the proximal one is wholly from the urogenital sinus, and
Okay, they join together and the
join
complete
together.
of the urethra is formed.
So the proximal urethra is endodermal lining, and the distal
Endodermal lining.
glands is a ectodermal lining.
Ectodermal lining, yes.
Yeah, and it starts around 4th week of intrauterine life. This development starts around 4th week intrauterine life, and as already discussed, this development is influenced by testosterone.
Testosterone, yes.
And a deficiency of one enzyme can inhibit this development.
What is the enzyme, Uma?
So beta hydroxy, so
5-alpha hydroxy reductase. Okay, that actually converts testosterone into dihydrotestosterone. Testosterone itself cannot work on the target tissue. It is to be converted into dihydrotestosterone. So if that enzyme is absent, even in spite of the presence of the testosterone, the development of the genitalia, male genitalia will not occur because of the deficiency of that enzyme. Okay, now proceed for the what will you do for this patient?
So as the first the orthoplasty is done already, so we will proceed with the second stage, that is the urethroplasty. That is the construction of a new urethra in this patient.
Uma, do you think the patient was operated at the ideal time at the age of 3 years, 6 months, like that? At 4 years? Is it the ideal time?
No, sir.
Why?
So he is 4 years already, sir.
What time you will select for the proper treatment? What is the time you will recommend for the treatment of hypospadias? If everything is okay, the health is okay,
the age is earlier.
It can be done less than 1 year. Can be done.
It can be done even at 6 months, 6 months to 1 year, or around 1 year. You can tell. So why you prefer? Because if the penis is wider or big, the operation technical part is rather easier. In spite of that, why you choose to operate at 1 year of age? So in children, because of the lack of tissue or less tissue, it's difficult, yet you choose to prefer to operate at 1 year. Why?
I don't know, sir.
Because you have to complete the operation. Some of the patient may need operation in stages. Multiple operations may be needed. You have to complete the operation before the child enters into the school, which is around 2.5 to 3 years. So if there is some anatomical defect, the child, the boy may be teased by his peers. Okay. And more is the presence of that anomaly, more is the psychological pressure on the child when he grows up, or also the psychological problem of the parents you should also take into account. As early as possible, you have to correct the defect so that the psychological aspect of the patient as well as his parents are addressed properly, taken care of. Okay. And the cosmetic result in a child following repair is claimed to be better than the operation on an adult skin. Sometimes the hypospadias operation is done even before marriage. Okay. So actually, what are the problems the patient may have with hypospadias other than passage of urine?
So, like you said, in the before marriage, patient can have difficulty in erection and difficulty in sexual activity. So,
and not only that is not a defect in erection, but in the difficulty in proper ejaculation in proper place. The semen will not fall in the proper place if the hypospadias.
The infertility
will be the problem. Infertility will be the problem. So, so you will plan to treat this patient. The part of the treatment has already been done by conic erection. Then what will be done?
So now we can proceed with urethroplasty.
Urethroplasty. So in this patient, as it is
anything else to be added to this urethroplasty plus the urethra is not at the top of the glands. So
the myotoplasty,
you may need a granuloplasty also.
Granuloplasty.
So if this operation has 3 components. orthoplasty, correction of chordae, urethroplasty, creation of a good urethral tube and bring it to the top, and granuloplasty. So there are three components. One is done and the two are remaining.
Okay. So you can combine the rest two operations together. Okay. So three component can be done all together as a single stage procedure.
Yes.
And the technique of operation may be divided into stages. First orthoplasty, then you can combine granuloplasty and urethroplasty and granuloplasty together. If you try to do it, if there is a failure in granuloplasty, you can do the revision granuloplasty as a third stage. Okay, so now tell me, what are the principles in urethroplasty? What are the principles? There are so many techniques, so many procedures are done for urethroplasty. For the mid-penile hypospadias, which procedure may be suitable for this particular patient? One option you can discuss. We can discuss. Body correction has already been done.
So there is a technique. There is transverse prepucial island flap technique for urethroplasty.
Okay. Okay. What is that actually?
How do you create the urethral tube?
So you are using a transverse prepucial flap. Okay, from the inner layer of the prepuce. So that prepuce transverse flap can be utilized as a tube or as a
tubularized flap.
Okay, as a tubularized flap, or it can be used as an onlay flap. So if it is a tubularized flap, you have to make a tube from the transverse or rectangular layer of the inner layer of the prepuce with a vascular pedicle attached to it, and that tube will be mobilized to place urethra, neo-urethra. Okay, so if you do a only flap instead of a tube, what will you do? What is the principle? How will you do the only flap? This is the basic things. For that I am asking in detail. There are so many techniques. What is only flap?
You have a good urethral plate. You have good urethral plate. And now how to do the second alternative?
So you can make a layer, rectangular layer, long rectangular layer on the ventral aspect, on the dorsal aspect of the neo-urethra. That is, on the urethral plate, you make two parallel incision. Okay, and two parallel incision we join behind the urethra, original urethra, and that incision will be extended up to the glands. Okay, so that is one wall, and over it you will make a onlay flap which is brought from the prepuce. Okay, Uma.
Okay.
You understand? Okay.
Yes. Yes.
So another term which may often be asked in your exam, what is TIP? TIP.
TIP.
What is TIP? It is a very popular technique. Most of the hypospadias operation, in most of the hypospadias operation, this technique is added. What is that? TIP.
Transfers. I don't know.
Actually, that is a Snodgrass technique. Then the term. Do you know what is Snodgrass technique? So as we were discussing that we can make a two parallel incision on sides of the urethral plate. You make these two parallel incision and you add an additional midline split, an additional midline incision. Okay. With that incision, you may create a groove in the middle of the urethral plate. Okay. Do you understand? It is not clear. Without diagram, it may be difficult.
Yes.
So, okay. Instead of, in addition to two parallel incision on two sides, you make a third incision in the midline. Okay. So if you accommodate a urethra in the if you accommodate a catheter in the neo-urethra, that incised groove will accommodate the catheter very snugly. There will be no tension on the suture line. So that is the added advantage of making the neo-urethra with a midline incision. That is the Snodgrass, that is also described as Snodgrass incision. Okay.
Yes.
Okay. So you have made a tube, urethral tube, by a tubularized flap or a onlay flap. How you can reinforce the suture line of the neo-urethra. So there is a ventral suture line. So to make it leak proof, how you can add tissues on the surface of the urethra.
We need a vascular cover.
Give it vascular power. So if you give some added tissue, connective tissue particularly, that will give vascularity to that particular region. How you can add the connective tissue? It's not difficult, Uma. So from the adjacent tissue, what are the areas where you can get the connective tissue?
You can take a layer from the scrotum. What is that layer?
Scrotum is very rich with connective tissue. All the beneath the skin there is a thick connective tissue layer. That is a dartos layer. Okay, you can add the dartos from the scrotum, and some surgeons prefer to go beyond or deep to the dartos, that is the tunica vaginalis.
Yeah.
So they add tunica vaginalis. So either you can reinforce that new urethra which you have made by suturing in the midline by adding the connective tissue flap either from the dartos of the scrotum or from the tunica vaginalis. Okay, so that will give support to the urethra you have created, and that will be finally covered with the skin layer which is borrowed from the adjacent your
dorsal root of skin.
Okay, so already you have made the adequate skin on the ventral surface, bringing it from the prepuce, dorsal hood of the prepuce. Dorsal hood of the prepuce is now brought to the ventral aspect by Cody correction. During Cody correction, so there is loose redundant skin.
Yes, so there was loose skin ventrally.
And that skin will be utilized to cover the urethra you have created. Okay, that is the basic technique in this procedure. And there are various techniques of urethroplasty, particularly the one-stage procedure. And what is Dennis-Brown principle of urethroplasty? What is Dennis-Brown? That is a very old technique, but still it is very appropriate for the repair of hypospadias if it is a proximal hypospadias. What is that? Dennis-Brown technique. Who's telling the principle only? Do you know, Uma?
No, sir.
Okay, the Dennis-Brown technique is urethral plate. Professor Shah and me are mention you. The urethral plate you can use for Dennis-Brown technique. So after Dennis-Brown technique is usually two-stage procedure. First, you make the correction of Cody, make the penis straight. Okay, then you have got a wide urethral plate, and you make two parallel incision up to the glands, and that urethral plate, if it is very wide, if the adequate skin is available, if the urethral plate is wide, you can make a tube with that urethral plate.
That plate only.
Or you can just keep that flap without making any tube. Two margins will be free, and you just wrap that plate of urethra with layers of connective tissue, and most superficial layer will be the skin. So what will happen? Now you have created a urethra having the epithelial lining on the roof. On the ventral surface, there is no epithelial surface. But if you keep the catheter in the neo-urethra for more than 3 weeks or around 3 weeks, then epithelium will grow around the catheter to make a complete urethral epithelialized tube. So that is the original Dennis-Brown technique. So original Dennis-Brown technique was only a flap was used, the complete epithelialized tube was not formed. But now the surgeon sometimes make a tube, complete tube, and cover that layer with multiple layers of connective tissue. So that is the Dennis-Brown technique, and that is a very good technique, widely followed, particularly for the proximal hypospadias, and cosmetic result is also unique. Okay. Dr. Professor Saha, ask
Yes.
questions.
Uma, have you heard of Indian surgeon who is famous for hypospadias repair?
Yes.
He is from Agra. He has devised an operation like it's a tubularized flap, Ashopa technique. Although a lot of people has a lot of modification with that, but Ashopa is famous for hypospadias.
Yes, erythroplasty. Yes,
Yeah.
sir.
Uma,
Yes.
if you study the evolution of hypospadias surgery, you will see that there are so many development in the evolution. There are very unique things. The time is short, we will go for your Ectopia. But remember, initially, long back, the treatment of hypospadias was to amputate the penis distal to the urethra, so that the urethra will be at the tip. Though it is short, but urethra will be at the tip. You amputate the distal part of the penis distal to the your urethral opening. Okay.
Yeah.
And Ashopa, and there are so many failures, and when Ashopa developed this technique, as Professor Saha has mentioned, so that was widely acclaimed as a good technique, because a tube was formed and that tube was passed through a opening or through a artificially made tube coring of the glands, and that cored tunnel within the glands was used to place that urethral tube, which is prepared from the prepuce. Okay, so what happened? This tube, when it was placed within the glands, when the glands surface, the tunnel was contracting, there was stenosis. So many patients developed stenosis with this technique. So Ashopa's technique is not popularized now. It is not yet not being followed now. And nowadays, the glands flap is made, but never a coring of the central coring of the glands is done, through which a epithelialized tube is placed. So that coring of glands is an obsolete technique, and most of the time the glands flap is made, and glands flap will be used to form to cover the neourethra. Lateral two flaps are made. Okay. Professor Saha,
Thank you.
another
Ectopia.
next case. Okay. So remember, hypospadias is a clinical case in an entity, congenital entity, which can be corrected nicely if proper techniques are followed. Sometimes one stage procedure is sufficient, but sometimes the multiple stages are required, and psychological aspect of the baby and the mother or parents are to be also taken into account. Now, complications after surgery, one is your stenosis, we have mentioned. Another is fistula, it is a dreaded complication. Patient may have
Urethrocuteneous fistula.
after correction of the fistula, re-fistula may occur. Okay. And body which was corrected, that may again develop after your urethroplasty if the proper technique is not followed. Hemorrhage is the earlier complication.
It's a hematoma.
Postoperative period hematoma, and we should also flap necrosis is one of the main problem of development of this, is the main cause of development of this fistula and other thing. Okay, so vascularity of each flap during repair is to be ensured, so that each flap have a good connective tissue attachment. Each flap during operation should have a good connective tissue attached to it. Now we can pass to the next case.
Yeah, Ectopia.
Excellent.
Brief,
Okay.
It will be short case. You need not go to the depth of whole general survey and others. You give a brief history and examination finding.
Okay. Now I'm presenting the second case. It's ectopic vesicae. Okay. Then the child is having a continuous dribbling of urine since birth from the exposed raw surface in the lower abdominal wall, and and the
give the history.
okay.
Give the history.
Okay, sir. And there is occasional bleeding occurs from that raw surface due to the friction, and it is associated with mild skin excoriation also. And he has a deformity of external genitalia since birth, and has multiple episodes of fever with burning micturition and pain in the lower abdomen. And he has difficulty in crawling and walking. The birth history, the marriage was non-consanguineous. Maternal age is 30 years. No history of any teratogenic drug intake. No history of any smoking or alcohol intake in the mother. The birth order is 1, and the baby was term and delivered by cesarean section. And the birth weight was 3.1 kg, and the child was exclusively breastfed. And there was recurrent episodes of UTI in the postnatal period, and patient was immunized as per national immunization schedule. His diet was mixed Bengali diet. Sleep was poor at the night time, especially. Appetite was normal. Bladder habit, urinary incontinence is there, and with a continuous dribbling of urine, and bowel habit normal. No significant family history. My summary, a 3-year-old male child presented with continuous dribbling of urine since birth and born with a defect in the lower abdominal wall with the genitalia as well, with exposed raw area from where urine used to dribble continuously, and occasional bleeding from raw surface due to friction, and complaints of recurrent episodes of burning micturition, fever, pain in the lower abdomen, and difficulty in crawling and walking. Examination. The patient is examined in well-lit room in supine position.
Uma, yes. You have mentioned it's a 3-year-old child and difficulty crawling. Why you have mentioned crawling? Because 3-year child will not crawl. Okay.
So in crawling and walking, he used to have difficulty in.
He may have difficulty in crawling, but at the moment you should not mention crawling. It is for the neonate, for infant, not for the 3-year-old male. Okay.
Okay.
Yeah, that will be difficult in walking. Yes.
Okay, continue.
I've examined the patient in a well-lit room in supine position after taking proper consent from the mother and the child and exposing from mid-chest to mid-thigh. The child was active and alert, but somehow irritated, well-built and nourished, no pallor icterus, cyanosis clubbing edema. His height was 90 centimeter, weight 12 kg, and mid-upper arm circumference was 13 centimeter. And there was widening of symphysis pubis and mal-rotated pelvic bones and gait problem.
Clinically difficult to say. Mal-rotated iliac bone is a radiological finding. You can say about the gait. That patient is walking with warping gait. Okay, it's difficult to say that clinically the bones are mal-rotated.
You can mention widening of the symphysis, or there is a softness between the two symphysis because the gap between the two pubic bone. But as Professor has mentioned, the mal-rotated iliac bone is not possible to say by clinical examination.
Clinical. Okay.
Then
his vitals are apparently normal. On inspection, there is a presence of red mucous membrane in the lower abdominal wall, anterior abdominal wall. There is deficiency of infraumbilical part of the anterior abdominal wall with visible posterior wall of the bladder with continuous dribbling of urine, and the ureteric orifices are not that much appreciable. The umbilicus is absent, and the edges of the abdominal wall is visible. The penis is hypoplastic, and there is a complete Hypospadias. The scrotum is normal, and the perineum is short and broad, and both the lower limbs are externally rotated, and bilateral inguinal region have fullness. On palpation, there is deficiency of the infraumbilical part of the anterior abdominal wall and anterior wall of the bladder. A gap is felt in the infraumbilical part and of the anterior abdominal wall through which the posterior wall of the bladder is protruding. The edges of the abdominal wall can be felt. The penis is short with complete Hypospadias, and there is associated inguinal hernia on both the sides, and both the testes are normal in place and well descended. Systemic examination is apparently normal. Summary: a 3-year male child presented with continuous dribbling of urine since birth, and he was born with the defect in lower abdominal wall and genitalia as well, with the exposed raw area from where the urine used to dribble continuously, and occasional bleeding from a raw surface due to friction. He also complained of recurrent episodes of UTI, and he has difficulty in walking. On examination, there is deficient anterior wall of the bladder and infraumbilical part of the anterior abdominal wall through which the posterior wall of the bladder is protruding with dribbling of urine. Umbilicus is absent. penis is hypoplastic with complete epispadias, and there is a bilateral inguinal hernia with normally descended testes, and both the lower limbs are externally rotated, causing gait problem.
Okay.
So my provisional diagnosis is a case of ectopic vesicae in a 3-year-old male child.
Okay, fine. Fine, Uma. You have very nicely included all the points related to the Ectopia vesicae. What is the other name of Ectopia vesicae? The other term which is often
the
used?
bladder ectopy.
Ectopy, very good. That is ectopy of the bladder. So
Ectopy.
you have examined the child. You have to also include the examination of the anus. Many a child, the anus may not be properly placed in its it may not be sighted at proper position. It may be more anteriorly placed. Okay, so you should also mention that anus is placed in its normal position and the sphincter contraction around the anus. By touching it, you can find the contraction. Some of the patients may have incontinence of the feces. So you should mention also the sphincter contraction around the anus. And spine, you should also include in your examination. Some child may have the defect in the spine. Okay, so you just tell me the background of this Ectopia vesicae in embryogenesis.
What is the abnormality? What happens in the region of cloaca?
So the cloacal membrane.
What is genital tubercle? And what is the role of genital tubercle in the formation of the phallus and the anterior abdominal wall? Ectopia vesicae, etiology, the embryological background, it is a ectodermal failure, endodermal failure, or a mesodermal failure.
Ectodermal.
No, it is mesodermal failure. Because in that tubercle which appears in the lower abdomen, in the region of the symphysis pubis, that mesodermal component will contribute in the development of the phallus, the corpus of the phallus, as well as that will give the same tubercle will prolong upwards to give contribution to the muscles of the lower abdomen. Okay, so the failure of that mesoderm to work properly will give rise to this defect. Okay, so anterior wall of the urinary bladder and the anterior abdominal wall is formed from that tubercle. So if that is not formed, so there will be deficient, and the posterior wall of the urinary bladder will bulge forward because of the increased intra-abdominal pressure. So the intra-abdominal pressure will push the bladder and that will look forward. Okay, so what is the, so it is actually part of the bladder Ectopia epispadias complex. Okay, so what is the extreme form of anomaly in Ectopia vesicae?
The whole of the anterior wall of the bladder is deficient, and
okay, actually the urinary bladder, what is cloaca? Tell me what is cloaca?
Yeah. Actually, cloaca is found in amphibians, where you have all three orifices in one place: the urethral, the genital, and the anal orifice. Okay.
So you know the foregut, midgut, and hindgut. Okay.
Yes.
So
yes.
what is hindgut? What are the regions which will be contributed by hindgut?
So here hindgut will rectum will form.
What is urorectal septum? Any idea? You should read it. In this class, it will not be possible without diagram to explain everything. So you must see, all the students are all requested to see the diagrams of development of the hindgut, cloaca, the urethra, the urethras, as Professor Shah has mentioned. Okay, so the cloaca may not properly form. That may remain exposed anteriorly. Okay, in the form of cloacal ectopy. Cloacal ectopy is a combination of this Ectopia vesicae and ill development or mal development of the gut structure, like the colon, rectum. Okay, the colon is not formed. It will end, the development of the intestine will end in ileum. So ileum will open into the extropy, cloacal extropy. Okay, there will be no anus. So that deformity is known as cloacal extropy, where the urine as well as the small intestinal content will come out through the same aperture in the lower abdomen. That is the cloacal extropy. Okay, so that is the extreme form of this complex defect. And the less extreme form is the epispadias only. Remember? So now tell me what complication may develop in this situation with ectopia vesicae.
Already mentioned some problems.
Yes, a UTI. So the patient is having a recurrent infection, recurrent UTI.
Yes.
So urinary incontinence is there.
Yes.
And
if the patient is not reconstructed, if the cloacal extropy is not constructed, so if remain exposed, how long the patient may survive?
So there can be neoplastic changes.
Yes.
And then further,
Can there be a
patient
reflux?
may lead to reflux.
Can there be
So
reflux?
yes, sir. So it can be hydronephrosis, then renal failure.
I remember, Uma. So to save time, you say if this extropy remains for a long time, there will be recurrent UTI, the patient will develop renal failure. Okay,
renal failure.
So that is most of the patient will lose most of the patient after fourth decade of life. But cases are also reported where the patient has survived beyond 70 years. Okay, so if the patient survives for long, and as you have mentioned, the neoplastic changes may happen. What type of neoplasm or malignancy may happen into the ectopia vesicae?
Squamous cell.
Usually it is adenocarcinoma. But if it is in the trigonal region, that is the squamous cell carcinoma. Okay, actually in my life, I have seen one case when we were just MS student like you, a patient presented at the age of 60 years with this ectopia vesicae. But there was no malignancy, only the recurrent UTI infection, and the patient presented with the problem of hernia, big inguinal hernia. Okay, but otherwise the patient had to manage with difficulty the urinary incontinence. Urinary incontinence is a very psychological traumatic to the patient, and the uriniferous smell with the patient with dribbling of urine, the patient will have persistent uriniferous smell. Wherever you will go, the people all around will get that smell. So that is very difficult for him, and he make him socially segregated. That is a main problem with those patients. Okay, now what is the actual age of correction? When you will start the treatment of this patient? Suppose it is a male child.
Sir, very early, sir, 6 months.
No, it should start within few weeks. If there is a body defect, until and unless you take care in the early stage, so you cannot bring the edges of the bladder together. So you have to correct the bony defect, and you have to close the bladder at the earliest time within few weeks after birth. So ectopia vesicae surgery is always a stage procedure. Multiple stages are required. First stage is to close the bladder.
Bladder, yes.
And during that closure, you may need the bony operation, osteotomy. Okay.
Yes, iliac osteotomy. Then
iliac osteotomy you may need for the correction of the malrotation, correction of the rotation, the ilium bone you mentioned. So after the closure of the bladder, next stage, what is the next stage?
So after closing the bladder, so that bony correction, iliac osteotomy.
You will do the urethra formation, epispadias.
Yes, the repair of that epispadiasis and urethra reconstruction.
After few months or after a year, you can do the epispadias correction. So till then, there may not be the proper sphincter function at the bladder outlet, because that is corrected later. Because once you correct, yes, so you have to do the sphincter reconstruction after the correction of the epispadias.
Yes, the continence and the anti-reflex
that will make the bladder continent. Okay. Suppose if the patient presents late, this patient presentation is very late, 3 years. Yet we have to try this reconstructive procedure. Suppose the patient present at the age of 20 years. What will you do?
Age of 20 years.
At that time, the reconstructive surgery may fail. because the bony gap is so high, so big bony gap, you cannot bring the bones together. You cannot properly reconstruct the sphincter. If you fail to bring the bones together, you cannot, neither you close the bladder properly, neither you can reconstruct the sphincter. Okay, and the bladder is already fibrotic. The urinary bladder musculature is already replaced by fibrous tissue because of repeated infection. So bladder reconstruction, sphincter reconstruction is very, very difficult. Most of the time it fails. So in that situation, you have to do something. What is that?
So the diversion.
Urinary diversion. How you can divert the urine?
Sir, ureterosigmoidostomy.
Okay, very good. And if the patient, what are the problems with ureterosigmoidostomy?
Sigmoid, so sir, that infections, the recurrent infection will be there.
And patient should be continent. Patient should be anal continent.
So okay, if there is no anal incontinence, so
there will be gross electrolyte imbalance, because urine in the sigmoid colon and the rectum, that will be absorbed, and that can lead to gross electrolyte imbalance.
So hyperchloremic
acidosis.
What are the alternative? Yes. What is the alternative to ureterosigmoidostomy?
So sigmoid, in the place of sigmoid, we can take ileal loop.
Yes, yes. You can make an ileal conduit.
Ileal conduit.
Okay. Yes. Or you can take the cecum or the terminal ileum, and that you can make a bladder with the cecum. And then you can do the Mitrofanoff's procedure. Okay. Appendix.
Which procedure, sir?
Mitrofanoff. Have you heard Mitrofanoff?
No, sir.
Okay. That's where the appendix is used as a tract up to the cecum. Cecum is made as the bladder, and through the appendix you can introduce the catheter, that is the clean intermittent catheterization, CIS. The term, remember, CIS is clean intermittent catheterization. So in that way you can make a continent conduit.
Conduit. Okay.
Until unless you catheterize, the urine will not flow. Professor Saha, ask a question.
Yeah. So if in desperate situations only you go for a ileal conduit, otherwise the primary aim is to reconstruct the bladder, then do a urethroplasty and do a sphincter reconstruction. And some cases may have ureterovesical reflux. Yes. So if you have a ureterovesical reflux, this reflux has also to be addressed. Otherwise, patient may have hydronephric change. So one has to also exclude any vesicatory reflux. And if the reflux is there, you should correct that also.
Okay. So, actually, as Professor Saha has mentioned, that should be remembered by all of you, that with Ectopia vesicae, even after correction, after reconstruction of the bladder, the vesico-ureteric reflux is almost present in 100% of cases. Close to 100% of vesico-ureteric reflux is present, and that can be corrected by re-implantation of the ureter into the bladder. And many cases need the augmentation of the bladder. The bladder is so small after reconstruction, you can increase the size of the bladder by ileoplasty, ileocystoplasty. You can bring a segment of the ileum to reinforce the bladder size. Okay. One question, when the time is short. If the Ectopia vesicae is properly taken care with reconstruction, can the child may have a normal parenthood?
Yes, sir.
Yes, yes. So yes. That is a great assurance which can be given to the patient and his parents, that this child, if treated from the very beginning, from the neonatal stage, if the treatment is started, the normal life may be offered to the child with normal continent urinary bladder and also the normal function of the genital tract. Okay, so even few decades back, the hope with the Ectopia vesicae was too poor, but nowadays with proper surgery and proper care by good team of specialists, including the surgeon, surgeon and the your physicians, anesthetist, a good functioning bladder can be given. Thank you.
Yeah, Dr. Maiti,
Yes.
if the phallus is hypoplastic, is there any role for giving hormone like androgen?
Yes, yes. In hypospadias, what I do routinely, I use the surface androgen. Testosterone cream I apply. Some surgeons prefer the injection, sustanon, testosterone injection, but the side effect of systemic androgen are many. But if you use the surface androgen in the form of cream, then the local effect is good. And each and every patient of hypospadias, if gets the surface androgen, the vascularity of the skin will improve. And to my observation, I believe that the size of the phallus also increases with local application of the androgen. That is very good. And
This is described
that is
usually
my
for
observation.
hypoplastic phallus. This is described usually for hypoplastic phallus.
Hypoplastic phallus, not routinely. If you see that the size of the phallus is good for the hypospadia surgery, then you may not wait. And if you see that it is hypoplastic phallus, then you have to apply this androgen to the surface so that it will improve. And always remember, in case of hypospadias with undescended, particularly the bilateral undescended testes, the sex determination is a must. Okay.
To determine sex, Uma, how can you assign genetic sex? What do you study?
So karyotyping, genetic karyotype.
Yes. How do you do that? Just a buccal smear. You do a buccal smear
Yes,
and look for bar body.
Yes.
Uma, remember that buccal smear is the easiest way, and other alternative is the neutrophil study. Okay, you examine the neutrophil, leukocyte, and there you can also find the bar bodies. So there are so many interesting aspects regarding hypospadias. I hope you will read further, and then our knowledge in hypospadias will improve.
You have a good discussion. That is how you go through a standard MS examination. You need not go much depth into the exact technique of operation, but you should know only the basic principles, what is being done for a particular operation. Okay.
Yes.
Another clinical part in hypospadias, I must mention that how you test the body clinically and at operation. Clinically, you hold your penile skin dorsally. On the dorsal aspect of the penis, you hold with your thumb and the middle finger, or thumb and index finger, the dorsal skin, and you compress it. And with compression, a penis without cody will not bend. If there is a cody, then the penis will bend further. So that is a good technique of excluding to assess the extent of cody by pressing on making the penile skin tense by pressing dorsally. And at operation, the technique of observing the cody is injection or infiltration of normal saline into the corpora, where the needle is pushed through the glands. So that operation, that is the technique of testing the presence of cody or the extent of cody.
Okay. Thank you, Dr. Maiti. Uma, thank you. You have presented very well.
Thank you.
Good. That is what is required for a standard MS examination. Thank you.
Thank you.
Thank you. Thank you, Dr. Maiti.
Thank you.